to this. Marvelous. So thank you everybody for joining us. What we're going to be talking about this evening is the conservative management of ingrowing toenails. This is by popular request. So if you all wanted something different, you've got no one to blame but yourselves. How do we manage ingrowing toenails? It depends. It's a cliche, but it's true. You cannot make a singular recommendation, a singular treatment plan that works for all of these sorts of things in all of these situations. So we have to break things down into component types. There are 3 grades of ingrowing toenail. A grade 1 ingrowing toenail is when there is an involution or a wide nail plate, the nail is pushing in at the side and there is pain.
Do I push start video?
No, somebody's not muted. Who's gone and unmuted themselves?
You've unmuted it.
There we go. Just keep your self muted because otherwise nobody can hear what's going on. So grade 1 is painful but with no pus, blood or anything else. The nail hasn't actually broken the skin, it's just pushing in. Grade 2 is when you have somebody needs to mute themselves. Y'all can't be doing this at the same time. I'm going to make it so that you can't unmute yourself. So if anyone does have if there is a major problem, you'll have to phone me. Grade 2 is where there is pain and the nail has broken the skin. So you will either have blood or pus, more inflammation, but no hypergranulation. And grade 3 is where we have hypergranulation, this overgrowth of tissue over the side of the nail. So when we're talking about what we're doing, that's the terminology we use. An involuted nail, something like that, which does not cause any pain or inflammation, is not ingrown. It doesn't count as an ingrowing toenail. So an involuted nail is simply curved. An ingrowing toenail is a curved nail with pain and or swelling. Onychocryptosis is just another name for an ingrowing toenail. A PNR is when we take the corner of the nail off. Now that's terminology that any podiatrist watching might not be familiar with. I hadn't heard that before I started hanging around SME folk. That's a fairly local piece of terminology to SME. But a PNR is just cutting the distal corner of nail off. And a PNA is removing a slice of the nail to make the whole thing less wide. So in terms of conservative management, that is to say non-surgical management, grade 1 conservative management is most of what we do, which is not to say that surgery can't be appropriate for a grade 1, it often is. But most of the people who come into clinic and say, well, my nail's a bit sore down the side, you just do a conservative job on it. It doesn't usually require surgery. Grade 2, sometimes you can get away with conservative management. But quite often, if it's actually broken the skin, we do have to resort to something more surgical. And quite often when it's like that, we have to use a local anesthetic, even for a conservative management. And grade 3, it's almost impossible to manage that conservatively. It's almost impossible to manage that without a local anesthetic and or a tourniquet. Hypergranulation, which is the main characteristic of a grade 3, is very, very vascular and very richly innervated. It's full of blood and it's full of nerves. So if you try and cut that or scrape it away, your patient will A, probably scream, and B, probably spray blood up your clinic wall. So that grade 3 almost always needs referral to surgical management. Grade 2, occasionally you can get away with conservatively. Grade 1, which is a vast majority of what we see in clinic, we can usually manage conservatively. There are a few issues with conservative management. The main one being that nails grow. Anything that we do to a toenail short of surgery will be undone by the passage of time. It's like having a haircut. Doesn't matter how good the haircut is, 6 months later, it's going to be back again. It's going to be the same as it was. Also a good analogy to use when people say you obviously didn't get the corn out because 6 weeks later my corn is back. Well, yes, if we cut your hair, then 6 weeks later your hair would be back too. It doesn't mean that we didn't cut your hair well enough. Nails grow, so conservative management is by definition temporary. Partial nail avulsion, the surgery is safe. It's got a fairly low complication rate if it's done well. And it's got a very high success rate if it's done well. So it's a very satisfactory option where it's appropriate. And in deciding whether it's appropriate, deciding where to send these patients, we have to look at the balance of risk. There are no absolutes in the management of ingrowing toenails. There are no if X, always Y. You have to look at the risks with conservative management and the risks with surgery. So with conservative management, the big risk, it's not even really a risk, it's a certainty, is recurrence. Whatever you do is not going to last. It is almost certainly going to come back. It can be painful and it can work out very expensive. If somebody needs regular management, if they need that nail treated conservatively every 6 weeks for the next 5 years, that works out as an astronomical amount of money. So in the long run, it can be more expensive. With surgical management, it is a risk that you can have recurrence or a complication. So we do have to make them aware of that, but it's a much lower risk. Procedural apprehension, being frightened of having a surgical procedure, is probably the single biggest risk. And that's not something we should underestimate, and it's not something we should invalidate. If you really, really hate needles, and the idea of coming back every 6 or 8 weeks or 12 weeks doesn't scare you in the least, but the idea of having surgery does, then conservative management's a perfectly reasonable option. That would make the surgical issue more of a risk. We've got to bear in mind that patient experience is as important as the outcome. Patient experience is the measurement of the outcome. So if they're frightened of nail surgery, it's absolutely valid to manage them conservatively. There is an upfront expense with nail surgery if they have it done privately. It's usually less than conservative management in the long run, but for some people, if you don't have £400 burning a hole in your pocket, then that can be a reason that they can't have it done. There is the risk of complication, particularly if we have a tissue viability issue, or a compliance issue or a social issue that would make that difficult. They have to do all the redressings. With every single patient, you have to weigh these options. There's never a right and wrong one. And slap bang in the middle, we have the patient choice. Whatever else our views are, the patient's choice is paramount. With the exception of if they want surgery and they're not suitable for it, in which case we simply won't do it. If they choose conservative management and it's safe for them to do that, that takes precedence over everything else. So, excuse me. Looking at the etiology of an ingrowing toenail. Generally speaking, what it is the corner of the nail. Sometimes it's a whole edge, but almost invariably it's a corner of nail which presses into the sulci, the pocket that the nail sits into. That little pocket there is the sulcus, and it causes pain. And this is where the term ingrowing toenail is usually misleading, because it's very rare that the nail is actually growing into the toenail. The vast majority of ingrowing toenails is the flesh being pushed into the nail rather than the nail growing into the flesh. There are a few exceptions to that, which we'll look at later on, but it's worth keeping that clear in your mind. An ingrowing toenail is not the nail growing sideways out into the toe. The nail is growing upwards, but it's usually that corner where the flesh gets pushed into the nail. So in terms of risk factors, and I've used the term risk factors, other people might use the term causes. We don't like talking about causes because when you talk about a cause, it sort of suggests a singular thing. It suggests this one thing happened and that's why there's a problem. It's always a matter of a constellation of factors. Nothing ever happens in isolation. But there are 5 main risk factors for an ingrowing toenail. One is a very wide nail plate. So this one is not very curved. It's not particularly involuted, but relative to the size of the toe, it's quite wide. That's a genetic thing. And we'll all have patients where we see every member of the family. I've had people where I've done 4 different generations and I've done nail surgery on all of them because they all have this very wide nail plate. If you have a wide nail plate, you're at much greater risk. The vulnerability of the nail fold, how robust that nail fold is. We've got a nail there and the nail fold is being pushed into it. If that nail fold is good and strong, the tissue is well perfused, it's healthy, it's much more likely to resist damage from the nail. The reasons for a vulnerable nail fold could be the classic tissue viability stuff. It could be ischemia. It could be thin skin, atrophy sort of thing. Or it could be something like hydration. So one of the reasons that teenagers get it is they've got very sweaty feet, which means they have very soft skin, particularly in that nail fold, which makes it more vulnerable to damage from the nail. Another thing that can make the nail fold vulnerable is if you soften the skin. And that usually happens when well-meaning people or parents put Savlon on an ingrowing toenail. Savlon, of course, being a cream base, they slather it in Savlon, they put a plaster around it, softens up the nail plate, and remembering that it is this pocket here and the nail pushes into it, if you soften that skin, you're more likely to get damage. So what we do not want to be doing with these as a rule is softening that skin. So we don't want to be putting any kind of emollients, any kind of creams, anything that will irritate the skin, God forbid tea tree oil. We don't want to do anything that's going to make that nail fold more vulnerable. The classic one is a very curved nail, this involution, because of course if the nail is curved, then pressure from the top, from the dorsum, is going to push a point of nail down into the skin, as opposed to if it's a nice flat nail, where pressure from the top will just push the flat of the nail into the skin. So a curved nail. Trauma. You can have a perfectly normal, perfectly happy, healthy nail that is not too wide, not too curved, and not cut badly or anything like that. If you drop a bowling ball in it, that toenail is going into that sulcus. So that can be acute trauma or chronic trauma, being things like kids wearing shoes that are too small. Football boots is the absolute classic. You buy your kid football boots, you send them off to school, you forget about it for 6 months, they grow 3 sizes, they don't tell you that their football boots are too small, lo and behold, ingrowing toenail. Shoes which are pointed, anything that chronically damages the toenail, that chronically traumatizes the toenail, can cause an ingrowing toenail. And bad nail care, the shape of this distal corner, which we're going to talk about in more detail. If you end up trying to cut down the side, what tends to happen is people cut part the way down, but don't quite make it to the edge. They leave a spike or a shoulder or a little ridge of skin, or even just an angle that's too obtuse. That can irritate it. Most ingrowing toenails will have one or more of these elements in. It'll rarely be just one, it'll usually be a combination. And when we're looking at our management strategies, we have to look at how much from column A, B, C, and D is at work, because we have to address all of the etiological factors if we can. So if you've got somebody who you can't get them out of football boots, but you can get them to stop putting Savlon on the toe, or somebody where you can't control the fact that they sweat a lot, but you can get them to change their socks regularly throughout the day. If we address these things one at a time, if we actually look at them individually, we can make sure we've covered all of the bases. So in managing an ingrowing toenail, there are 4 main tools we have at our disposal, 4 main angles of attack conservatively to try and deal with it. We can reduce the pressure from the nail on the nail fold. So whether it is the flesh being pushed into the nail or the nail being pushed into the flesh, if we can remove or reduce that point of pressure, that can help. We can cut the nail at an angle. This is your PNR, to reshape the nail in the transverse plane, i.e. looked at from the top down, put a curve on that edge. That will remove that point of pressure. We can also reshape the nail in the frontal plane looked at from the front. This is where the nail is curved. We can use bracing to try and uncurve that nail or reduce the curvature of nail, reshape it that way. Really important one that often gets missed, we can reduce the extrinsic pressure on the nail fold. In other words, if there is something pushing that flesh into that nail, if we can reduce that pressure, then we can reduce that point pressure at the point of impact. So you can either sort of, by reshaping it, by doing a PNR, something like that, you can stop the nail pushing into the skin, or you can stop the skin pushing into the nail. Either achieves the same goal. And last and least, we can sometimes put something between the nail and the nail fold. This is sort of packing or sulcus injecting. We'll look at each of these individually. So in terms of reshaping the nail, so this is your most basic fundamental sort of idea. We have the question, patients always ask us, should we cut the nail square or should we cut down the corners? And the answer is, if there is no corner, if there is no point at which the corner of the nail is pushing into the sulcus, there will be much less trauma, there will be much less impact pressure. An edge of nail pressing into a sulcus is much safer than a corner of nail pushing into the sulcus. So if you just push a blunt edge of a knife into an apple, it won't cut. The same amount of pressure with the tip of the knife will. So I'm not actually, that's the blunt edge pushing quite hard, same amount of pressure but further down. That's what will happen with your ingrowing toenail. So if we can, we want this. We want the flat edge of nail pressing in rather than a corner of nail pressing in. So wherever we can, we want to allow the nail to grow out to leave that corner free. That's the safest way. Very often that's not possible, whether because of the shape of the nail or the shape of the toe or the way it works or the fact that the patient won't leave it alone or because it breaks. What tends to happen is we end up with this situation with the corner of nail pushing into the toe. And it's this corner which is almost invariably the problem. So what happens is the patient has a nail like that and they cut the corner off and it takes the old corner point away. It feels better for about 2 weeks, but now of course they've created a new corner a little further down. So what they do is they cut another line down and that relieves that corner of pressure and creates a new one a little bit further down, and so on and so forth up to the point where they can't cut any further down because they've run out of space. This is the patient's home care version of a PNR, and it's wrong. It is going to cause more problems. So when we cut down the side, when we reshape the corner, the first thing we need to do is find the edge of the nail. We have to know how far that edge goes down before we try to make a cut in this direction, because if we don't, we're just guessing. We're just pushing the nippers down and hoping we've reached the edge. So the first thing we have to do, and I've got a video on this, is to actually use the Black's file to find the edge of the nail. To do this, you will need a Black's file. For ingrowing toenails, it's fairly straightforward. You just get the smallest, thinnest, flattest, finest Black's file that you can find. It's a lot of fun at conferences going through all the different things. You want something ideally which is rounded at the tip, which is very, very flat, and the finest thing you can find. If you want to know what the right sort of bulkiness of a Black's file is, get one of your Black's files and try and shove it down the side of your own sulcus. You'll find very quickly the benefits of a skinny one. The other thing I would warmly suggest that everybody do is to have 1 or 2 sets of ingrowing toenail clippers, which are just for ingrowing toenails. So in terms of nippers, we've got your bog standard Garden variety, use it on the cat, use it on the horse type bulky nipper. I'm not a fan, but that's what most people use for everyday stuff. Then you've got your technically an ingrowing toenail clipper, which is what I use for most things. But then we've also got these very, 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 very skinny ingrowing toenail clippers. Now, if you use these for regular routine work, the tips will bend outwards because they are so fine. They are not designed for regular use, and they're not designed for anything that's going to have any kind of force on it. What I would suggest is you get 1 or 2 sets of these, you sterilize them separately, you pouch them separately, very possibly with one of your fine Black's files, and you keep those nippers for just PNRs, nothing else. You don't use it for any other function, just PNRs. It keeps them sharp, it keeps the tips of the nippers opposing nicely, and your patients will thank you so much more for putting that down the sulcus of their nail rather than the thicker nippers. They do need to be sterile because there is a reasonable chance you're going to break the skin. So if you are somebody that uses patient-held instruments, which is absolutely fine for most things, you can't use it for this. It needs to be a sterile set of specifically the finest you can get ingrowing toenail clippers. And when those nippers get old, when inevitably the tips, when you push them together, the end just does that when it slightly flexes, get rid of them, throw them away, buy a new set. They're not expensive. You do need the right equipment for the job. And then you need to look at the actual shape that we're looking for. So we've talked about how the patients do it with a straight line. So the nail goes across the top, and then they do an angle down the side, and then the side of the nail is there. So we have an angle at the distal end there, and an angle down here. Any kind of corner, no matter how sort of far down you go, is always going to be the flashpoint for a problem. The shape that you're looking for is a curve, not a straight line. It should not be a cut down the side. It should be a curve, a sweep around the side. You cannot do that if you have not found the edge of the nail. And if you leave an angle that is obtuse, you will leave a corner behind. And if you go too far down the nail, you will end up with such a small amount of nail there that will cause a problem. What we want is something that follows the curve of the toe. So if you consider the curve of the flesh, that is the curve that you want on the nail. There are very few straight lines in biology. So what we're looking for is to make it so that there is no single point there which is going to start to cause a problem. Ideally, when you've done a good PNR, you shouldn't be able to see where your cut finishes and the edge of the nail begins. So I'm now going to do the thing which always mildly terrifies any presenter, which is to try and use a video. So this is one that I haven't listed on FaceTube yet. So what we're doing there is, first of all, we have to find the edge. So, oops, sorry about the focus, it was going in and out. So try and keep the Black's file, if you can, parallel to the nail. You don't want to be going in at 90 degrees and using the tip. You want to be keeping the file in the same orientation as the nail. And what you do is you sort of go in over the top and roll it under the nail. I'm assuming that my screen is being shared here. Sorry, let me go back to the Zoom. Could somebody give me a thumbs up if the video is on the screen? It's not on the screen. There's a thumbs down. See, I've gone and messed it up already. How about now? Thumbs up if it's on the screen now. Yeah, there we go. Right, so I'll rewind it to the beginning and I'll start again. See, bloody amateur. Right, as I was saying, so the first thing we got to do is find the edge of the nail. It goes out of focus for a second there. Make it so I can see a few people. And then keep the blacks file in the same orientation as the nail, so parallel with the nail. What you don't want to do is what we often see, which is the nails like that, and people scrape the blacks file in at 90 degrees. That's not a good time. And you sort of put it in over the top, roll it around and draw it back. There's our little shoulder. This is a nail that somebody actually broke. The edge of that nail split, and they hadn't actually done anything with it. It's always better if people leave it for you to do rather than try and do it themselves. Then we get our nippers. Should be coming on screen in a moment. Oh no. So there what we've got is a camera, and that will show us the nail. So I'll pause the video there for a second. That's an intraoral camera. They're designed for dentistry, and they're really, really useful. If you use a laptop in a clinic, or if you have a computer when you do DOMS, they cost about 30 or 40 quid, and you can actually show the patient the spike in their nail. Patients really love this stuff. They love to be able to actually see what you're doing, and you can actually take a before and an after photo, which is great for your notes. So you can see there up close, looks like it's been cut with a chainsaw. You've got a crack there, a split there, a drop there, and then it comes back out there. So there's no wonder that was giving a certain amount of pain. So back to the super fun happy times. Then we're going to get our nippers. We're going to keep at 90 degrees so that we're cutting the right angle. Make sure we've got the tip of the nippers to the side. Take a little sliver off, and then go back with the blacks file, once again rolling it around and then sweeping it up. And we're trying to make that nice smooth curve so that it's not obvious where the corner is, and we're trying to follow that curve of the skin if we can. Shaving little slivers of nail off. The sort of debris that you get down the side of the nail there, the hard skin and whatnot, it's not massively harmful, but it's a good idea to get rid of it if you can, because it gives you more room to actually take some more nail off, and it means you can see what's going on down there. If there's masses of debris or onychophosis, you can't actually see what's happening. And we're just going to tidy up the excess. Different grips on the clippers so that you're always ergonomically appropriate. Sorry, it went out of focus a bit there again. And then one last time with the blacks file. So you're sort of doing a cut, smoothing the corners, a little bit more cut, a little bit more smoothing the corners. And then hopefully at the end we should have, so that's the finished article. That's what it looks like after you've smoothed it. So we've got a curve. There isn't really a corner there. So that shouldn't cause any more problems. That's the bit that was digging in. That was the inflection point. So that is your P&R. Just go back to the PowerPoint if we can. There we go. Give me a thumbs up if we're back to the PowerPoint. Marvelous. Got a couple of folk on the screen who are doing me a solid here. So that's P&Rs. Oh my word. I don't know if you can see that. There's bits in the bottom of my beer. That's not healthy. I don't mind cloudy beer, but oh my word. Tastes nicer. Brings us on to nail bracing. There are 3 flavors of nail bracing. Active nail braces are things which are in and of themselves elastic. They are trying to flatten the nail. They're trying to reduce that curvature, and they will actually exert active force on the nail. This would be something like a spang brace, a springy fiberglass strip. Pseudo-active nails, braces, are things which, when you apply them, they are inert. So if you put a gel strip across a nail with nothing on it, that's not exerting any force. That's the strip has molded itself to the nail. However, if the nail changes shape as it grows out, it will become active. So if you put it on the proximal end of the nail, it will try and hold that same curvature as it grows out. And passive braces, which are things like metal braces or gel strips when they're applied in a different way, are things which simply hold the nail into the shape that it's been pushed into. So by some way or other, you shape the nail physically, and then you put a rigid something on the top of it, which holds it into the shape that you've made. So looking at these in a little bit more detail, I've picked an example type of all of these braces. I'm not being paid by anyone here, sadly. Other types are doubtless available. This is just an example. So a spang or spange brace is a springy fiberglass strip. It's reasonably simple to do. All you need to do is prepare the nail. You need to degrease it and condition it. You need to prepare the strip. You have to actually abrade the backside of the strip, slightly abrade the nail, and you essentially super glue the strip to the nail. You can leave it on. It's very low profile. It's difficult to see, and if they want to put nail varnish over the top of it, that will cover it up. And then you just reapply them as you need to, or as the nail grows out. You can use multiple strips on the same nail, either one in front of the other or even one on top of another. And by doing that, of course, you will increase the amount of springiness. Advantages of this sort of system is it is pretty simple to use. I say simple, not easy. There's no major technique to learn. There's not a long, complicated process. There's not a course you need to go on to use these. And because we're simply gluing something to the top of the nail, it's pretty safe. Unless you start spraying super glue or nail glue all over the patient's foot, it's very hard to hurt them like this, unless you really try. They can be inexpensive. The actual formal spang system that was in the previous slide costs a couple of £100. But if you go on eBay, you can buy a little pot of the springy strips, and I think there's some nail glue that comes with it as well, for £6.60. The strips are the same. I've got a spang brace, and I've bought some of these extra strips off eBay to replace some of them, the ones that I've used up, and they are, as far as I can make out, exactly the same. It's a bit like custard creams, whether you buy them from Sainsbury's or Asda, they're made in the same factory. So it's an inexpensive thing to get and use. And you can also use it for repairing split or broken nails. So if somebody has cracked a nail longitudinally, or if they've torn it and it's gone down below the level, you can use this system just to repair it. You can stick it over the top almost like a suture, and it will stop a split running. It'll stop it catching on anything. Patients really like it for that sort of thing. It is fiddly as balls to apply. because you've got something which is elastic, which is springy, and super glue, which, as we all know, you can hold the two bits of the vase together for 3 days and it won't stick, but you touch it with your finger, that vase is now a part of you. It really fiddly to apply, so it takes a little bit of practice, but you're not in any danger of hurting a patient whilst you're practicing. They're not very strong. The amount of force that strip can exert is not very great. So if you've got a thinner nail on a pediatric patient, for example, or a fairly average adult nail that you can reduce down, it might be enough to change the shape of the nail. If you've got a thickened, corksic, graphotic, or just tough nail, this is not going to do anything. It's just going to sit on the top. So you have to pick your patients for this one. The sort of pseudo-active systems, Onifix being the one that I've seen most often, consists of applying a strip of something inflexible to the proximal end of the nail, the end nearest the person. Most nails like this are more flat at the proximal end, and they curve in as they grow out. So if you apply a reinforcing strip to the proximal end, as it grows out, that strip will try and keep it the same curvature. So it's not actually doing anything when you apply it, but as the nail grows out, it resists that tendency for the nail to pinch in. This is not one that's got a nail brace on it, but I included it because it's a really lovely example of one of those that grows in as it pinches more as it grows forward. See how much wider that nail is at the base and how much more pinched it gets at the distal end. If you could make that nail that curvature, the proximal end curvature, all the way down, that person would certainly benefit. They are fairly simple to use. Again, we are in the realms of putting something on the surface of a nail. It doesn't involve cutting into anyone or twisting anything or putting any instrumentation or anything like that. Therefore, it is reasonably safe. The only major caution you have to have with any kind of UV system, any kind of UV cure gel, is of course you have to put sun cream on the skin, because you are applying quite a lot of ultraviolet light to the skin. Not expensive, not difficult. You just have a pot factor 50 in your clinic, a little dab around the skin of the sulcus, don't get any on the nail, perfectly safe. So it's, broadly speaking, there's low risk involved. The equipment is a lot more expensive. You can't buy this sort of thing from eBay for a tenner. You need the light to cure the gel, and the gels themselves can be more expensive, so outlay is bigger. And it is only really effective for nails which involute in as they grow out. If the nail is a uniform curvature proximal to distal, then the brace is not going to do anything. It's just going to hold it where it already wants to be. So there's a very specific therapeutic group where this type of brace is useful. And the last one is passive braces. And this is something which is not elastic. It holds its shape, much like the ones that we looked at a second ago, but you somehow flatten the nail physically before you apply it. So with a wire brace, you put the hooks around the side, then you tighten it up yourself, and that pulls it, and then the wire holds it in place. With these little darlings, you clip the hooks around the edges of the nail, put the screws on, and then you put a rigid strip across it while it's in that position. Then you release that, and hopefully the nail stays put. This is an Arcada's cube, which is a weird looking thing where you put these, you put the cube in this rig, and there are screwed on blades that you can manipulate, hold the nail where you want it, and then put gel over the top of it. Some people will pack cotton wool under the edges of a curved nail to push it out, put the bracing over the top of it, then remove the cotton wool, and hopefully it stays put. these are, of all the braces, the most difficult and complicated to apply, because you've actually got to physically yourself reshape the nail and then hold it into a position. It often involves anchoring or pulling from underneath the nail, so you've actually got to get underneath it, and that involves the risk of trauma. So it is less safe than others. And because you have got something usually under the nail, there is a risk that the body is going to treat it as a foreign object. If you've got a piece of wire hooked around the side, if that digs into the sulcus, there's a risk that the body will treat that as a spicule and produce hypergranulation around it, in which case that's not a good time. You can, however, with a passive brace, exert a lot more force. There is potentially a role for it because it can really pull up a lot harder. So looking at nail braces collectively, they're not going to give you as much relief as rapidly as a PNR. A PNR, cutting the corner off the nail, will immediately get rid of that spike and usually immediately get rid of that pain. If you are using a nail brace in isolation, it's going to take longer for that to work. So it doesn't give you the quick fix that you get with a PNR. And it does involve leaving something in situ on the nail, which has got all the potential problems of patients taking it off themselves, or it breaking, or it displacing. It does involve leaving something there. It might offer you better medium-term relief than a PNR, because where a PNR will have grown out within sort of probably 6 to 8 weeks, a nail brace, something like the pseudoactive Onifix brace, the one where you sort of reduce the curvature, that's more likely to give you relief potentially for a few months, not weeks and not years. Sooner or later, the braced portion of nail will grow out and then you're back to where you were. So it's not a permanent solution. It's definitely not a replacement for nail surgery. And one of the reasons that some pods don't like nail bracing is because sometimes it is proposed as an alternative to nail surgery. It is a temporary fix. It falls between a PNR and a PNA. It's a middle ground. And sometimes for some patients, it can be useful. I saw a chap today that I used a nail brace on, middle-aged chap. He was a farmer, so he's wearing wellies and boots all day. Inside of the wellies and the boots was a little bit funky. He had diabetes and he had fairly poor glycemic control. He had a grade 1 with a little bit of a spicule. He really wanted nail surgery. I didn't fancy doing nail surgery on him because he's not going to be able to sit at home and rest the toe. He's not going to be able to look after the wound very well. He's medically high risk, but just taking the corner off, he's not going to come back in 6 weeks. I know this because I've seen him before about a year ago. So he needed something that was in the middle. So for him, with his quite involuted but quite thin nail, a nail brace was a good option. It's non-invasive, so if you've got a really nervous patient that won't let you near them with anything sharp, sometimes this can be something to look at. And this one, we are addressing the curvature of the nail rather than the width of the nail. So if you've got a wide nail and the width of the nail is a problem, this isn't going to do anything at all. In fact, it might even make it worse because by straightening out, you'll make it wider. But if you've got a curved nail, this can be useful. Third thing, this is my favorite thing, reducing the extrinsic pressure. So, as I said, generally speaking, aside from nail spikes, the nail isn't usually actually growing in. Ingrowing toenail is usually a misnomer. Usually we have a corner of nail like this. There is an extrinsic force there pushing in and it inflames at that corner. There is such a thing as an ingrowing toenail. Sometimes there is a spike which does grow in. This was a PNA that I did a few years ago. And what had happened is the chap had cut down the side, but not quite made it to the edge and left a little spike. And then the next time he'd cut again, and so on and so forth. The spike of nail actually had grown through the tip of the toe. And you can see on there, it had actually, there's a puncture wound. You can actually get a probe right the way through it. That is a genuinely ingrowing toenail by any yardstick. In that case, the nail growing forward was what drove the nail into the flesh. But usually that's not the case. Usually it is a corner or a shoulder, and it's simply pressure. If we can reduce that pressure, we can reduce the ingrowing toenail. Tale as old as time. More often than not, the ingrowing toenails that we will see in clinic, I always think we see more lateral ones than we do medial ones, more on this surface next to the second toe. And that is because more often than not, if you look at the big toe, the distal phalanx is slightly abducted. In other words, the big toe is not usually straight, it's usually hooked slightly over towards the second toe, which means that if you look from the top down, you will see a gap at the base of the second cleft. There's the gap there. There's the gap there, and the contact point is at the tip. Very often as well, the big toe will sit slightly on top of the second toe, so that when you walk, it has that sort of scissoring action, and that pushes the pulp into the nail. All of the pressure between the second and first toe is then concentrated on the nail, and that is very often why we get an ingrowing toenail, not because the nail is pushing into the skin, but the skin is pushing itself into the nail. And you would be amazed how much you can achieve here with a simple interdigital wedge. So if we want to reduce extrinsic pressure, we can't ever get rid of pressure, but we can move it around. If we put a wedge right down in the cleft, right down in the proximal cleft between the first and second toe, proximal to that IPJ, so that we do not want to have a wedge up here. If you put a wedge there that is between the tip of the toes, you're just going to increase the pressure. It's got to be there. You can put the pressure, instead of being between the second toe and the nail, between the shaft of both toes, which will greatly reduce the pressure and usually immediately reduce the pain. You have got to make sure you've got room to do it. If you push the big toe outwards and it causes the outside of the toe to press on the shoe, then of course you've robbed Peter to pay Paul, but usually there is. You can use Otterform. That's a nice, fairly hygienic medium to long-term solution. You can use semi-compressed felt and just give them a little sort of 1 centimeter square block of felt that you put between. You can use a piece of cotton wool and put a bit of Hyperfix just to hold it between. You can use a silicone wedge, something like this. Whatever is appropriate for that patient, they can use. The lovely thing about this as well is that you can actually explain to the patient what is happening, explain how it works, and then they can do it themselves. So if you've got somebody with an ingrowing toenail that just flares up now and again, you explain to them what to do. If they find themselves at a wedding and their ingrowing toenail starts hurting second to first, go into the ladies, fold up a little bit of toilet paper, all gents, shove it right down in the gap between the toes so that the second toe doesn't touch the first. Immediate relief. On the outside, which is somewhat less common, the most usual reason for extrinsic pressure is either footwear or a valgus rotation of the toe. When we talk about hallux valgus, we tend to think of this angle here. We tend to think of the big toe going over that way. Valgus is actually a frontal plane rotation. It's the thing that means that side of the toe becomes closer to the ground and that side of the toe lifts off the ground. So a valgus rotation of the toe will mean that that edge, that sulcus of the nail, is pushing more into the nail. Very, very arguably, valgus rotation of the foot, i.e. pronation, might also do that. The reason I'm qualifying that a lot is because the rotation is usually nowhere near that sort of angle. And because, unfortunately, our profession has a sad history of people issuing orthotics from everything from rabies to night blindness. So I'm always a little bit suspicious of folk who claim to have achieved great things like fixing ingrowing toenails with insoles. It's vaguely possible, it's plausible within the model. I'm a little suspicious of it. But certainly addressing the footwear, and if you've got that rotation of the toe, then just a little blob of semi-compressed felt under the IPJ will just lift that off the ground so that the ground is not pushing into that lateral edge, if that's the problem. This here is actually my my daughter's toes. She has had a PNA on that nail on that side. Which hopefully gives you the idea that if you do it well, cosmetically, you can't even see that a PNA has been done. But you can really see there the whole thing of why she developed that ingrowing toenail, because her big toe hooks over that way, pushes into the second toe. When she walks, the big toe pushes down and that pulp is pushed up. That sort of ottiform, just to create a little bit of separation, not too much, but just enough so that there's a tiny bit of air between the first and second toe, makes a big difference. Doing this is safe, it is painless, it can be effective medium to long term. Very often the patient can apply it themselves. It is very rare, to the point of being impossible, that this is not a good idea to do. Either some sort of wedge or addressing the footwear or looking at the rotation. You always need to be thinking, this is a cliche, of the biomechanics, because this is biomechanics. An interdigital wedge is an orthotic. It's a biomechanical intervention. So whatever else we're doing, we always need to be considering that as well. It's very rare that this is enough, that this will just solve the problem. But it's equally very rare that this is not helpful to consider. Brings us on to the last of our four things, putting something between the nail and the nail fold. So if the nail is going down there, if we can introduce something between the nail and the sulcus, hypothetically, we can give relief. Sometimes this is called sulky packing. It's a slightly mucky term because sometimes people use packing to describe putting loads of cotton wool to actually change the shape of the nail. Sometimes I mean just a little wisp of cotton wool. It's usually cotton wool, but there is also such a thing as sulky injectors, these little silicone tubes that you can put between there and there. Sometimes it can give relief if the sulky is very sore, very vulnerable. Sometimes it can be used effectively in conjunction with bracing, i.e. you use the packing, you then put the brace on, then you immediately remove it. You must not use this if there is any bleeding or exudate or oozing from the sulcus, because what will happen is it will bleed into the cotton wool, that blood will clot, that blood will go hard, and then you've got a plug of hard, crunchy, clotted cotton wool embedded down the side of the nail, which you're going to have to remove, and that's going to cause trauma. And we do not want to be leaving anything, especially cotton wool, in situ for any length of time. It is a fabulous environment to breed bugs. You can get fungal growth in there, bacterial growth in there. It's not a good idea to leave it for more than a few days. Consider it to be like a wound dressing. You would put a plaster on a cut on your finger for a few days and it will help. If you leave it on for a few weeks or a few months, it will be rancid. We do not want to be leaving cotton wool down the side of people's sulky. And there is the problem that the body can treat it as a foreign body and reject it, and then you get hypergranulation and such like. So, summing up, I don't know how I'm doing for time. Oh, look at that, I've not overrun. Always, 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 we are assessing the patient before the toe. Is it a one-off problem or a regular? Is this because they've dropped a cantaloupe on their toe and it's unlikely to happen again, or is this happening every 3 months? What kind of solution are they looking for? We all have our ideas about how we can best fix something, but if the patient isn't interested or is frightened of needles or frightened of probes or doesn't want anything stuck to their toes because they want to paint them, we have to work around what they want. We have to consider their medical history, their social history. How old are they? What's their tissue viability like? Are they taking anticoagulants? Do they have diabetes? Are they immunosuppressed? And we also have to think about their more sort of holistic elements. What's their job? What's their footwear like? What sports do they want to play and how important is it to them? Are they about to go on holiday? Are they about to run off and do their Duke of Edinburgh award, in which case a short-term fix is exactly what they want? Or are they looking for a solution for the rest of their life, in which case a long-term fix is what they're after? We have to assess these before we look at the toe. If we're thinking about surgery, and we always have to consider it as an option, what are the risks of doing it? And what are the risks of not doing surgery? Because it's not a zero-sum game. It's not a question of surgery is risky, therefore we do conservative management. It's always, is surgery more risky than conservative management? Because both have risks. Inaction is itself an action. And then we need to assess the toenail, having first assessed the patient. Is it a grade 1, a grade 2, or a grade 3? Is there inflammation? Is there bleeding? Is there hypergranulation? Is the nail a very wide nail, in which case you're always going to be on a sticky wicket unless we end up making it narrower? Or is it a very curved nail, in which case we may have some function to trying to reduce that curvature? How thick is the nail? How brittle is the nail? What is the shape of the offending corner or edge? Is there a spicule? Is it simply a shoulder? Or is it neither? Is it simply that the nail is too wide or too curved? And what is the extrinsic pressure? Is there an element of trauma? Is it footwear? Is that big toe abducted at the tip? So it's the tip of the second pushing into the tip of the first. Is it a valgus big toe or a valgus foot? What are the extrinsic pressure elements? You add that column to that column, you get a treatment plan, you get a strategy. And you can present that to the patient as, this is what you've got, this is why we think you've got it, these are the options for treating it, these are what we think would be the best options for you at this point, and then you listen to what they have to say. So